Welcome everybody, and thank you for joining us for the next in the series, the IHM series of webinars and discussions with people who are actually out there doing the job. Now, I think all of us know very well, don't we, the terrible, terrible price that this virus has taken both on families and our loved ones and our businesses and the economy. It's wreaking dreadful damage. But there are some good things that are coming out of this. There is a brighter side, and that's what we want to focus on for the next 25 minutes or so. The brighter side of what's emerging from the management of the COVID crisis. Now, guests today are from the Royal Wolverhampton NHS Trust. We have David Loughton, the Chief Executive, Professor Steve Field, who is the Chairman, and Sultan Mohammed, who is the Director of Integration. Gentlemen, welcome to you all. Now, the reason we wanted to visit or pay a virtual visit to the Royal Wolverhampton is that they're starting a campaign that actually we're going to latch on to with the Academy of Fabulous Stuff. It's called No Going Back. And the idea is that there are things that we're doing differently. Force majeure have made us do things differently. And these are the things that we're going to say at the end of it all. You know what? We don't want to go back to the old ways because we found some new and better ways. Faster, quicker, efficient, safer. So that's what we're going to look at for the next few minutes. And perhaps we could start with you. We better start with the chairman, start with the boss. Chairman Steve, good morning, good afternoon, good evening, whenever it is you're watching us. How are you doing and what are you doing?
Well, I mean, I'm doing really well, thank you, and the Trust is doing very well. And just, I think, to say a few words about context, I've been here for a year now, having recently been at CQC and the College of GPs, and it's great to come back home to what I believe is probably the most innovative trust in the country, in that we have a large number of GP surgeries, community care, we have acute and tertiary care, and all of that is joined up and integrated. And we work extremely tightly and well with our Director of Public Health, our Council, Adult Social Care, Children's Social Care. So really it is a joined up city. And the best has come out during this past few weeks of where the virus has hit us, in that it really has demonstrated that under pressure everybody can work together. Even the football team, Wolves, is playing a great part in what we're doing as well. So I think we've got a fantastic base to move on to a really innovative future where there's nothing like a crisis to allow people to unfreeze things and move forward. So what we've got to do is build on great work that David has done and Sultan, to innovate and really provide a different form of care and healthcare provision for the people of the Black Country.
Well, thank you for that, Steve, and that puts it in context very nicely. Let's move to David, if we may. David, tell us, give us a top line of some of the innovations that you've been sort of forced into doing that you think, you know what, this is good stuff.
Yeah, I suppose I'd start off by saying for probably the last 2 or 3 years, I've done loads of talks about accountable care systems, and the system that I sort of admire the most in the world is Canterbury in New Zealand. And I usually finish off my talk by actually saying, well, in Canterbury, they had to reorganise their healthcare system very, very quickly because they had an earthquake. And I used to say, well, I'm not holding my breath for any time soon for there to be an earthquake in Wolverhampton. Little did I know how wrong I was going to be.
No,
because
do not tempt Providence.
Well, we have just had the earthquake.
Yeah.
You know, things that would have taken us 2-3 years to organise and implement, we did in a week.
Yes.
You know, loads of people hid behind what you can't do, what the rules, the regulations are, and they were just thrown out of the window because, you know, the mother of invention is necessity. And we had to organise, you know, outpatient consultations completely differently and a whole manner of things. So I think the biggest thing that's happened, and the advantage that certainly Sultan has had, is a lot of our ideas that we've been kicking around with for 2, 3, 4 years, we've implemented in a matter of days. So I think that has been really good. And I'm absolutely clear that there is no going back. We do not want to go back to what we were doing before. I regularly walk past our A&E department and the waiting room is empty. And, you've got to ask yourself the question, why is it empty to the degree that it is, and why was it so full before?
Yeah. Can you answer that question, David?
No, I can't answer that question if I'm honest, but I think that, all I can say is if you make a service accessible, guess what? It will get accessed, because we, as part of the Mid Staffordshire Foundation Trust, were winding up. When A&E closed at Stafford overnight, and this is back in 2011, we got exactly 50% of the predicted ambulances that were going into Stafford at night, and so did Stoke. And I jokingly say, when the ambulance turned up in Stafford and they said, where would you like to go to, Wolverhampton or Stoke? They said, oh, I'm off back to bed now, because that disappeared. And that's gone on since 2011. So I think when you make something difficult to access, it doesn't get accessed in the same way. There is a downside to that, and the downside is I do believe at the present time a lot of people are frightened to come to an acute hospital. And I mean, we've got the top-rated ambulance service in the country in the West Midlands, and, they were appealing yesterday, if you're really ill. There was a story about a lady who had laid in bed for a week with a fractured hip before they phoned the ambulance. So I think we've got to get over this fear of, if you are ill with something other than COVID, you still present. Yeah. And, I think that's really important.
That's very much the message we've had from the Downing Street press conferences for the last 2 or 3 days. But moving on to where we are now, let's say good morning to Sultan. Good morning to you. Now, we wouldn't be talking this morning if it wasn't for you, because you contacted me and said, we're doing some great stuff here and we don't want to stop doing it. And we think that you should showcase it at the Academy of Fabulous Stuff. So based on your instructions, I rang you immediately and here we are.
He never misses an opportunity to advertise.
It certainly doesn't. So Sultan, this is your moment. Just highlight for us perhaps a couple of the innovations that you've put in place that where you definitely won't want to pull the plug on them.
I think, as David and Steve said, this has been a 3 or 4 year journey. So, with general practice and community service in an integrated way, really, that base is where the Babylon proposition came from. So what we're trying to do in the city is have a digital overlay onto physical services, so the patient is seen remotely first, as far as possible, interacts with kind of computers and chatbots.
Okay, right. Let me stop you there, because that's quite important. So you've essentially you had the basis of a digital first service.
We had the basis. So the infrastructure David's put in place over a number of years was actually, we understood that to manage demand, you cannot do it just by looking at the four walls of the hospital. You have to think where 90% of the patient care is happening. So 2016, we started in the really meaningful integration with general practice. Full clinical and business transfer is the process that we started on. And actually, this wasn't a new idea. If you think of Kaiser in the States and kind of Gesundheits Kinzigtal in Germany and many other places, they've been shown to be quite good, New Zealand as well. So that's the basis for it, the integrated place space. And where Babylon came from was actually they wanted to...
Okay, let's just stop you there for people who won't know who Babylon is. Babylon is the app that gives you a video consultation underpinned by a sort of artificial intelligence that does a kind of triage screening and then passes you on to a clinician.
Yeah. That's right.
Yeah. So you've used that in the primary care context?
Primary care context, community care context, secondary care context, all three.
And we also developed with Babylon an app. If you've got COVID-19 symptoms, you can go onto the app and it will triage you through that and take you then to a clinician, which need not be a GP, but then you can move to a GP as well in real time.
Yeah. So this relationship with that you have with this provider has provided a, I mean, they've been a controversial company because of the difficulties they've had in reimbursement, but because you'd already embarked on this vertical integration between primary care and secondary care, I suppose that's made that assimilation into the system easier.
Yes, it's made it easier because, and there is a choice that the consultation with the GP can be either a consultation with one of our own GPs using the Babylon system, or it can be a GP provided under the guise of Babylon. Okay. So you've got a security, so you're not forcing people to necessarily interface with a GP that's not their own GP. So we've got, you know, a mix and match.
Yeah. Yeah, I get that. Right, I've just got an eye on the time, and I'd like to sort of move you on now to the things that you've done during the COVID crisis. I think you've done some interesting stuff around outpatients, haven't you?
Yes.
Okay, yeah. Who wants to tell us about that?
I think quite a lot of outpatients, Freud, based on the fact that clinicians understood that they needed to kind of see their patients still. A lot of them had a level of acute need. And it took, within 24 hours, when they worked out these patients still need to be seen, the fuse had gone in the heads of the clinicians across, you know, the 10,000 kind of staff. It was a big organisation. And whatever technology we could lay our hands on, from AccuRx, Babylon, whoever, you know, vendor agnostic, clinicians just embraced that technology. And what they're finding now is their efficiency has gone up. Their responsiveness to services has gone up, and they feel more connected to the patients. So that has happened across the piece within the organisation. That's the outpatient piece.
It's worth saying, though, we weren't starting with a blank sheet of
absolutely.
paper, because quite a number of specialties, diabetes particularly, where they've been doing remote consultations for a number of years. So we weren't starting off, you know, on day one that we got nothing. We'd already got quite a lot of infrastructure in there, and that was able to roll out. And particularly in rheumatology, they've done some fabulous work in terms of developing apps and being able to do everything remotely.
Yeah. So, Steve, if I could just come to you as a clinician, it does take a whole difference in approach to practice, doesn't it, for clinicians to rely on the signs that they can get on the screen, other than, I mean, normally if you go and see a GP, the GP will observe you walking in, how you sit down, what your attitude is, how you stand up, what your eye contact is. I mean, there's a lot of sort of subliminal signals in the diagnosis process that perhaps you don't get with what we could call, just for now, telemedicine. I know it's more than that, but so it does require a different attitude to diagnosis, a different approach from clinicians, maybe even different training.
Well, I mean, as Sultan said, I think this affects all of our clinicians, nurses, doctors, not just in general practice, primary care, but through to outpatients as well. And so if you're talking about the first diagnosis of a new patient coming in, that is slightly different to managing people from a follow-up point of view. And most clinicians have been using the telephone for years as, you know, as a big aid in the consultation. Very few patients need to be examined straight away. So you need a mix and match with this, where you can, if you're doing outpatients, you'll know the patients, you'll know their data, you'll be able to follow the data, you'll be able to talk to them and see them. In fact, adding the video adds something to it. And I think here the clinicians have been remarkably good. But again, as my colleague said, this goes back years and years. We have a very, very good group of doctors and nurses. That, I mean, we've had some of the best staff surveys and trainee feedbacks for 10, 15 years. So there's a lot of confidence in the staff and the management. And they work together very closely as a team. I think I've been hugely impressed.
Yeah. And Sultan, what about engagements with staff? I mean, picking up from the chairman's point about working with staff, have the staff come through themselves with innovative ideas?
I mean, this is the golden part of trust, really. Our staff, because of the culture that's kind of been here for a number of years, they have lots of ideas and they put their hands up. So we have lots of fora. And the main fora where this has come from is the Digital Innovation Forum, where any member of staff, whether it's a reporter or a consultant, can pitch up with an idea and say, hold on, I think we can do this better. It could be tech-based, it could be non-tech-based. What we then do is, as board members, we will support that process, putting their legs in it, almost like Dragon's Den, and give them kind of, if you like, the knives and forks to support them to take the idea into fruition. If we can do it internally, Roy, we will support them internally. If it needs external support, we have a whole ecosystem of partners that David has developed over a number of years to give us kind of added strength, if you like, collective strength. So through that, there are many things that have come forward. Training for junior doctors through a kind of app base came through one of our junior doctors. Again, that's now rolled out and people can access that. We've talked about the basics such as video consultations. We've talked about kind of meetings using Zoom and etc. These are really easy things, but sometimes the innovation could have been out there for a number of years. It's just that we haven't had it in England for long. We pick those up and we run with them. So embracing non-traditional sources of knowledge is what we really support staff to do.
I think, Roy, the word culture is so important. If you've got an organisation, this is the same as you well know in business as well as we're in the health business. If you've got a group of staff who trust each other, where the clinicians and the managers actually work together as one without any conflict, you can innovate, you can try things and actually be prepared to fail. And a lot of people in business would say that the marker of a successful business is the number of people involved in innovation and new things. And that's what you'll find here. People will come up with ideas, they'll try them. They might not work straight away as they might have thought, but other people will help them develop it. And frankly, if it doesn't work, they'll move on to another thing. So there's not a fear of trying things and failing. A lot of people are involved in research. A lot of people are involved in doing things in a different way. So nurses taking on what were traditional medical roles, etc. So it's a very exciting place to be.
And there's not a fear of waiting to get permission to do something.
Yeah.
That is.
Remember, David, you told me the story of where you were going home one day on the bus and the guy sitting next to you was a porter. And he said, I know you are, and you need to fix this.
Absolutely. I tell you what, that's the one thing that has really changed in this recent times, that I don't learn as much about the organisation on the bus as I used to, because I've had to give up public transport. You know, so many times, there's so many people in this organisation and throughout the NHS that have got some great ideas, but unless you create a culture that people will listen to those ideas, you're done for. And I just had it the other day. I met a porter in the corridor and, you know, he came up with something. I said, oh, well, none of my senior management team have come up with that. Thanks very much. I'll implement that.
And another one for COVID, which is worth thinking about, is that we were short of face masks for you know, the visors for COVID, and within 48 hours, 24 hours, we managed to get clinicians and managers working together, redeploy some of our staff. They're now making over 4,000 visors.
Well, we're up to 5,000 a day now, so I can give them to other organisations. And
so you're actually making them on the premises?
We make them on the premises. They're in our medical library, which isn't heavily used at the present time. Right. So we've got a team of about 20 people in there that we redeploy, and we're knocking out. We've hit 5,000 a day now.
So it's Wolverhampton master us.
Well, one of the anaesthetists actually sent me an email saying it's the best face visor of any that we've used so far. I did have someone, by the way, that said to me, well, they're not CE marked. And I said, yes, and what is the point?
Yeah, exactly. Well, I mean, this whole approach to regulation is really, I mean, I'm nervous about treading on the ground of regulation, given your chairman's past experience.
Don't worry about the chairman. He's poacher turned gamekeeper.
But I'm really wondering, I'm really wondering, you know, what exactly are the CQC going to do at the end of this? Because I know if they came to my hospital, I'd say, listen, where were you in COVID? I was running this place.
I mean, yes, I have to obviously be professional and careful. What I would say is I've come here because it's like coming home, and you know the reasons why I've come home. But this is an incredibly innovative trust. And if you were looking at business and you were looking at, you know, we basically weren't in deficit this year. We have an outstanding team, and Mike Richards, my colleague at CQC, would say the main marker for an outstanding organisation would be what happens in their staff survey and their survey of junior doctors. And this trust, going back a decade, has always been exemplary. So it's innovative, and the staff, we've got a waiting list of midwives, and we have clinicians coming to join our maternity unit from far and wide. There is not a problem with recruitment.
Yeah.
Really is.
And in fairness, there are very few trusts that can say that. Look, I've got an eye on the time on the clock here, because I know that you've got to get off and do other things. Just on that point of midwives, there was an item in the press this morning about the ability to continue to provide births at home, and how the midwifery services were doing, because I mean that is an intimate service that you can't exactly deliver 2 arms length away. How are you managing with that, David?
Well, not doing any home deliveries, but we've got to put this in context, right? You know, we do over 5,000 deliveries a year, and our average is 18 home births a year. In a city like Wolverhampton, it's not easy before this to do large numbers of home births for fairly obvious reasons. So it is not a big issue here. I mean, I've heard of it nationally, and it's completely different where you have got some relatively small midwifery-led units in very small towns. That's not the situation we've got here. I mean, we've got a very large midwifery-led unit within our own maternity unit, but we're doing over 1,300 deliveries a year through that midwifery-led unit, because you can take risk. You can take risk because if something goes wrong, it's literally 3 minutes down a corridor and you're into a consultant suite. That's completely different to running a midwifery-led unit, you know, 20 miles away from the consultant unit. So
absolutely, I get that. Look, Sultan, now, I know you've been busy filming some of these great innovations that you've introduced, and we're going to be featuring them on the Academy of Fabulous Staff. Give us, in a nutshell, give us a couple of some of these sexy ideas that are going to enthrall us all.
I think the one that's about to come, Roy, is really the data that we've got. So as you know, with AI, machine learning, quantum computing, the source material is data. So we have in Wolverhampton the richest data set on the planet, combining primary, secondary, community care in one foul sweep, and it's updated live daily. Now, if you think about AI and you think about anticipatory care, we will now subvert completely the care model where a patient doesn't need to ring up and say to a hospital or a doctor, something's wrong with me. We will observe the data and we'll go out to the patient before they get into a need. So that is going to be very, very different. That's our big idea. And underpinning all of that, really, is the clinical engagement and working across boundaries. We know that in the NHS, we haven't got the billions to invest in terms of AI. So we are not shy about forming partnerships with, we have strong partnerships in the States, China, and in Europe with a range of technology providers. So without going into specifics, Roy, there's a lot more to come. You'll see some of the videos in the next 2 weeks around things that we're already implementing.
Okay, tell us, give us a bit of a teaser on what we're going to see in the next couple of weeks.
Well, you'll have more detail on the Babylon proposition, the COVID Care 19 app. You'll see all of the things we're doing at the outpatient settings. Yeah. You'll see some of the technology that we've applied in different specialties, as David has already mentioned, rheumatology. There are some really interesting work. You'll see some of our medical education tools, which I think are class leading. But there are some things, Roy, which I will keep to myself for the moment because it will be another video at least.
Can I make a final point, Roy?
Yes, please do.
One thing that we've got to bear in mind with all of this, and it was great last night, you know, everyone's out there clapping for the NHS and key workers. That is really great. I can't remember back in 2008 anyone that was out there clapping for the bankers. And I hope when we get through all of this, this is not forgotten about the key workers in the NHS, because, you know, I never used to have a problem recruiting healthcare assistants. I have a problem now because a certain supermarket, which I won't name, you know, pays £2 an hour more than I do. And, you know, I hope that this doesn't get forgotten. A lot of the frontline staff that are dealing with this, they are paid the minimum wage, yeah? And particularly in the community, you know, some people are doing home visits, they get 15 minutes, they don't get paid travelling time. I hope there is a complete overhaul and value placed going forward on these frontline workers, and it doesn't get forgotten by a Thursday evening clapping session.
Yeah, I think that's a very important point, and I think I wrote something the other day about, you know, a so-called low-skilled worker just does the work that none of us want to do, and it's redefined the whole relationships. Look, I know you guys are up against it for time, and I'm grateful to you for spending some time with us and giving us some insights into how you're managing. I guess it's the right thing to do. They leave the final word to the chairman. What are you most proud of? What do you see the future like? And can you do that in about 2 minutes and 9 seconds?
So I think the whole thing is about people and the staff. So within the trust, it's the culture of innovation and for constructive challenge, about looking after the staff when they're under pressure. And observing what's happened during this crisis, we've actually had very high levels of morale. We have sickness down at 8%, which is amongst the best in the country. And I think that isn't something that's happened now. It's building on that for 10 years in the past.
It's also the fact we don't use agency staff as well. And that going through this has been really, really important for how well we've done in terms of staffing.
No agency, no locum doctors, stable workforce. People want to work here. Yeah. And the leadership is brilliant.
Well, listen, if only I could get out of lockdown, I'd come up and I'd apply myself. It sounds like a wonderful place to work. Listen,
hey, we couldn't afford you, Roy.
David, Sultan, and Steve, thank you so much for giving us your time. This has been a real peek behind the curtain, a look in the boardroom, a real privilege to talk to you. Thank you all for what you're doing in keeping us safe, and good luck with the future. And we're full of admiration at the Academy of Fabulous Staff and the IHM. You are, of course, a regional hub for the IHM, I should tell people. And so bless you all, and thank you very much for everything that you're doing.
Thank you, Roy.
Thank you.
Look after yourself. Stay safe.
Thank you.